Hello everyone. This is Ashraf Hassanpour from Shiraz University of Medical Sciences, and welcome to this lecture where we are going to be talking about the orbital cavity. We will begin our discussion with the bony orbit, and then we will talk about accessory structures of the eye that provide protection, lubrication, and support. The bony orbits are a set of incomplete cavities which surround the soft tissues that make up the eye. Like many other bony cavities, the function of the bony orbit is to provide a stable and enclosed environment for the eyeball and its adjacent structures. The bony orbits provide sockets for rotatory movements of the eyeball. The line axis of each orbit passes backwards and medially. The medial wards are parallel to each other at a distance of 2.5 centimeters, but the lateral wards are set at right angles to each other, provide sockets for rotatory movements of the eyeball. Axis passing through centers of the anterior and posterior pores of the eyeball is known as visual axis. It makes an angle of 20 to 25 degrees with the orbital axis. Beginning at the top or the superior aspect, the orbit is formed by the frontal bone. So frontal bone forms the superior surface or roof of the orbital cavity. Moving clockwise, here is the maxilla, which contributes to much of the anterior facial skeleton as well as the inferomedial part of the orbit. We can see the orbital surface of the maxilla here, which contributes significantly to the orbital floor. The posterior portion of orbital floor is defined by a small depression which is known as infraorbital groove or the infraorbital sulcus, which gives passage to the infraorbital vessels and nerve. The infraorbital groove continues into the orbital floor as the infraorbital canal before terminating on the anterior or facial surface of the maxilla as the infraorbital foramen. Next, we can see the zygomatic bone, which forms much of the infralateral part of the orbit. As you can see, it completes the orbital margin between the frontal and the maxillary bones. Inside the orbital cavity, we can see the zygomatic bone also contributing to the floor and the lateral walls of the orbit. These three bones collectively contribute to much of the anterior orbital cavity, forming what is known as the orbital margin or the rim of the eye socket. If we move further into the orbit, we'll find several other bones that also contribute to its walls. The sphenoid bone, seen here along the posterior wall of the orbit. The greater and lesser wings are forming a large portion of the posterior wall of the orbit. One landmark of importance close to the lesser wing is the optic canal, which is located antero-inferior to the lesser wing. A little lateral to the optic canal, you can see a rather large opening or cleft between the orbital surface of the lesser and greater wings of the sphenoid bone. This is known as the superior orbital fissure. Now, if we have a superior orbital fissure, it must mean that we also have an inferior orbital fissure, which is this cleft or opening. It's formed largely by the opening found between the greater wing of the sphenoid bone and orbital surface of the maxilla. The optic canal gives passage to the optic nerve in addition to the ophthalmic artery as they make their way to the ocular bulb or eyeball. Superior orbital fissure gives passage to a number of significant anatomical structures, such as the superior and inferior divisions of the oculomotor nerve, the trochlear nerve, some branches of the ophthalmic nerve, the abducent nerve, as well as the superior and inferior ophthalmic veins. Some of the extraocular muscles also have their origins close to this landmark, which we'll look at later on. Inferior orbital fissure, too, transmits several structures such as the infraorbital nerve and artery, which do not show in this illustration, and infraorbital vein, which is a branch of the inferior ophthalmic vein. We also have a number of smaller bones which contribute to the inner surface of the orbit. As you know, the ethmoid bone is located centrally within the cranium, and like the sphenoid bone, contributes to the medial wall of both the right and left orbits. So here we can see the orbital plate of the ethmoid bone. Slightly inferior to it, you will see another small piece of bone found in the posterior orbit, and you are looking at the orbital process of the palatine bone. And finally here, the lacrimal bone contributes to the medial wall of the orbit. And that's it. We have now discussed each of the cranial bones which form the orbit. Now let's talk about accessory structures of the eye that provide protection, lubrication, and support. So let's get into it, beginning first with the eyelids, also known as palpebrae. So your eyelids or palpebrae are two folds of specialized skin which cover the anterior or exposed portion of the ocular bulbs. Their primary function, of course, is to shield and protect the eyes from dust and other particles, injury, as well as from exposure to excessive light. They also assist in keeping the corneal surface of the eye moist. We do of course have two eyelids over each eye, a large superior one which is relatively mobile and serves as an attachment point to the levator palpebrae superioris, which you see here, and we also have the much smaller inferior eyelid which is less mobile. The eyelids are separated by what is known as the palpebral fissure and joined at their extremities as the medial and lateral canthi. Each eyelid can be subdivided into two parts: a small medial part which lacks eyelashes, known as the lacrimal part, and a large lateral part which does have eyelashes and is called the ciliary part. Each eyelid is only 2 to 3 millimeters in thickness and features a number of tissue layers. The skin on the surface of the eyelids is the thinnest skin over the entire body. It's relatively loose and is elastic to accommodate their movement. Just deep to the skin within the eyelid itself, you'll encounter a small amount of subcutaneous adipose tissue and then a skeletal muscle tissue, which is largely comprised of fibers from the orbicularis oculi muscle. This muscle is a sphincter that surrounds the entire eye. Its fibers are divided into two parts: the orbital part and the palpebral part. This is the orbital part. When this muscle contracts, it closes the eyes tightly. The palpebral part of the orbicularis oculi is just a bit closer to the margin of the eyelid. This is also a sphincter around the eye, and when it contracts, the eyelids close gently. Just deep to the orbicularis oculi muscle, we next encounter the tarsal plate. The tarsal plate or tarsus is a lined plate of firm, dense connective tissue that gives some structure and form to the eyelid. Each tarsal plate is connected to the medial and lateral borders of the orbit by means of the medial and lateral palpebral ligaments, which help anchor them in position. The superior tarsal plate is also secured by some fibers from the aponeurosis of the levator palpebral superioris as well as this muscle, which is also known as the superior tarsal muscle or Muller's muscle. Along with the levator palpebral superioris, the superior tarsal muscle assists in elevating the upper eyelid. However, unlike the skeletal muscle of the levator palpebral superioris, the superior tarsal muscle is made up of a smooth muscle tissue that is under autonomic or involuntary control. Embedded within each tarsal plate are small glands arranged in rows perpendicular to the margin of the eyelid. These are known as tarsal or Meibomian glands. Each gland opens into the free palpebral margin via a minute orifice. Now moving on to the next structure that you see here as a blue line, which is known as the conjunctiva. The conjunctiva is a thin mucous membrane that covers the sclera of the anterior orbit before being reflected onto the entire posterior surface of the eyelid. So, the bulbar and the tarsal conjunctiva are continuous with each other, and the point at which the two parts of the membrane meet is called the fornix. The word fornix means arch in Latin. The junction is called a fornix because at this point the membrane folds on itself and forms a curve. This forms a space known as the conjunctival sac, which opens anteriorly at the palpebral fissure. This junction is what prevents a contact lens from moving behind the eye. And with that, we've mentioned all the major components of the eyelid. It's time to move on now to our next structure, which is the lacrimal apparatus. Before we jump into the anatomy of it, let's talk about what the lacrimal apparatus actually is. The lacrimal apparatus is a group of structures responsible for generating tears and collecting and draining the tear fluid. The tear fluid is made up of water and contains many electrolytes, proteins, and more. It functions as a lubricant for the eye and protects it from infection. Now let's get into the anatomy and begin by looking at the lacrimal gland. As you can see, the lacrimal gland is an oblong gland about the size of an almond that sits deep to the zygomatic process of the frontal bone. The lacrimal gland is what produces tears. It is divided into two parts by the levator palpebral superioris. The orbital part, which is superior close to the bony orbit, and the palpebral part, which is inferior close to the palpebra or eyelid. And the lacrimal gland is the beginning of the lacrimal system. In order for the tear fluid to get from the gland to the eye, it travels through passageways called the excretory ducts of the lacrimal gland, which we can now see here. There are usually up to 12 ducts, all transporting fluid from the lacrimal gland into the conjunctival sac in the supralateral aspect of the eye. As we discussed in the previous slide, the conjunctival sac is the space between the layers of the conjunctiva that line the eye and the eyelid. On the medial aspect of the eye, we can see lacrimal caruncle. This is the pink fleshy part at the medial aspect of your eye, and it contains some sebaceous and sweat glands that secrete a whitish liquid. So you know it in the morning when you have gunk in the corner of your eye. That's your lacrimal chruncle at work. The lacrimal chruncle sits within the lacrimal lake. This is where tears accumulate when fluid is moved laterally to medially from the lacrimal gland to the medial corner of the eye. Once tears have accumulated in the lake, we have to empty that lake. That process involves structures called the lacrimal papillae, which, as you can see, are situated superior and inferior to the lacrimal chruncle. The lacrimal papillae is the medial part of each eyelid. In the center of each papillae is an opening called the lacrimal punctum. It is through the lacrimal puncta that tear fluid drains to continue through the lacrimal apparatus to enter into our next structure, the lacrimal canaliculi. Then two canaliculi join before opening into the next structure, and this structure is called the lacrimal sac. It is the superior portion of this vertically running tube which is called the nasolacrimal duct. After lacrimal fluid passes into the lacrimal sac, it travels inferiorly into the nasolacrimal duct until it exits through the opening of the nasolacrimal duct. The opening of the nasolacrimal duct is in a specific anatomical space that we identified earlier. And do you remember what it's called? Yeah, the inferior nasal meatus. So when we cry, our lacrimal gland produces more tear fluid than normal. Some of this excessive fluid will overflow and roll down our cheeks, and the rest will still try to drain through the nasolacrimal duct. But because there are so many more than normal, the tears continue running right out of our nostrils. Okay, that's it. And now I'm going to be talking about the muscles of the orbit. There are 7 extensing muscles of the eye: the levator palpebral superioris, the superior, inferior, medial and lateral recti muscles, and the superior and inferior oblique muscles. The levator palpebral superioris originates on the inferior surface of the lesser wing of the sphenoid bone and inserts into the upper eyelid. As the name suggests and previously described, this is the muscle responsible for lifting of the upper eyelid. So the contraction of this muscle elevates your eyelids. The 4 recti muscles, lateral, medial, superior and inferior, originate from a common tendinous ring. The common tendinous ring encloses the optic canal and middle part of the superior orbital fissure. Each of these 4 muscles passes into the orbit and inserts into the sclera of the eyeball a few millimeters posterior to the cornea in the position indicated by their names. These muscles function to pull the eyeball in the direction of the muscle insertion. The superior oblique muscle arises from the body of the sphenoid bone immediately above the superior rectus muscle and passes anteriorly to end in a tendinous pulley attached to the trochlear fovea of the frontal bone. From here, the tendon turns laterally beneath the superior rectus muscle to insert into the sclera between the insertion of the superior and lateral rectus muscle. The inferior oblique muscle arises from the orbital surface of the maxilla lateral to the lacrimal groove. The muscle passes between the orbit floor and the inferior rectus to be inserted in the sclera between the insertion of the lateral rectus and superior oblique muscles. We are now ready to move on to the functions of the extraocular muscles. But at first, it should again be noted that the axis of each orbit is directed slightly laterally from back to front, but each eyeball is directed anteriorly. Therefore, the pull of some muscles has multiple effects on the movement of the eyeball, whereas that of others has a single effect. So, for each of the rectus muscles, the medial, lateral, inferior and superior, and the superior and inferior obliques, a specific action or group of actions can be described. However, these muscles do not act in isolation. They work as a team of muscles in the coordinated movement of the eyeball to position the pupil as needed. So, main movement of the superior rectus is elevation or moving the pupil superiorly. Also contributes to the adduction, moving the pupil medially, and medial rotation of the eyeball. Contraction of the inferior rectus depresses, adducts, and externally rotates the eyeball. Contraction of medial rectus adducts the eyeball, whereas contraction of the lateral rectus abducts the eyeball. The superior oblique depresses the eye and turns the eye laterally. This muscle passes through a pulley-like loop called the trochlea in the anteromedial orbit. This muscle attaches to the superior posterior part of the eye, so contracting this muscle pulls the posterior part of the eye superiorly but depresses the anterior surface of the eye. And finally, the inferior oblique elevates the eye and turns the eye laterally. Since this muscle attaches to the inferior posterior part of the eye, contracting this muscle pulls the posterior part of the eye inferiorly but elevates the anterior part of the eye. Please note that, as I said, these muscles do not act in isolation. They work as teams of muscles in the coordinated movement of the eyeball. For example, although the lateral rectus is the muscle primarily responsible for moving the eyeball laterally, it is assisted in this action by the superior and inferior oblique muscles. Okay, we are done covering the different muscles of the orbit. Now we are going to be talking about the different blood vessels that you can find in the orbit. We are going to start off with one of the main arteries of the orbit, the ophthalmic artery. The ophthalmic artery is the first branch of the internal carotid artery, and it passes into the orbit through the optic canal with the optic nerve. In the orbit, the ophthalmic artery gives numerous branches, such as the central retinal artery that supply the retina, the ciliary, the lacrimal, the supraorbital, the anterior and posterior ethmoidal, the supratrochlear, the dorsal nasal, and finally some muscular branches. So as you can see, branches of the ophthalmic artery will be supplying all the structures in the orbit as well as some structures in the nose, face, and meninges. Now we are going to be talking about the veins. There are two venous channels in the orbit, the superior and inferior ophthalmic veins. The ophthalmic veins drain the orbital and receive tributaries which correspond to the branches of the ophthalmic artery. These tiny veins that you see here are known as the vorticose veins. They are also called sometimes a vortex veins, and they collect blood from the ocular choroid and drain it into the inferior and superior ophthalmic veins. Superior ophthalmic vein communicates anteriorly with the supraorbital and angular veins. It passes through the superior orbital fissure and then drains into the cavernous sinus. The cavernous sinus is a large collection of thin valve veins creating a cavity bordered by the temporal bone of the skull and the sphenoid bone. Inferior ophthalmic vein runs below the optic nerve. It receives tributaries from the lacrimal sac, the lower orbital muscles, and the eyelids, and ends either by joining the superior ophthalmic vein or drains directly into the cavernous sinus. It communicates with the pterygoid plexus of veins by small veins passing through the inferior orbital fissure. As you know, the pterygoid plexus is a venous plexus located partially between the two pterygoid muscles. Please note that because the ophthalmic veins drain into the cavernous sinus and communicate with the extracranial veins, they act as routes through which infection can spread from outside to inside the cranial cavity. Also, I'd like to add here another important clinical note associated to the vessels of the retina. The central artery is an end artery, so it does not have effective anastomosis with other arteries. Occlusion of the artery results in blindness. Also, as you can see here, the optic nerve is surrounded by the cranial meninges, including the subarachnoid space, which extends as far forward as the eyeball. So, any increase in intracranial pressure therefore results in increased pressure in the subarachnoid space surrounding the optic nerve. This may impede venous return along the retinal veins, causing edema of the optic disc. The retina and intraocular part of the artery can be seen in living through an ophthalmoscope. Now we are going to be exploring the different nerves that you find on the orbit. Let's have a look at the most famous of them, the optic nerve. So, as you know, the optic nerve is the second cranial nerve and leaves the orbit via the optic canal running posteromedially towards the optic chiasma. This nerve transmits visual information from the retina to the brain. Your eye's blind spot is a result of the absence of the photoreceptors in the area of the retina where the optic nerve leaves the eye. Now, in this slide, we have three cranial nerves that will innervate the muscles that attach to the eyeball. Innervation to the lateral rectus muscle is provided by the abducens nerve, a cranial nerve that serves only a single function. The abducens nerve enters the orbit through the superior orbital fissure. Another cranial nerve that you see here is the trochlear nerve. This one is the fourth cranial nerve and it's a motor nerve that innervates a single muscle, which is then the superior oblique muscles of the eye. The trochlear nerve is unique among the cranial nerves in several aspects. It has the greatest intracranial length and it is the only cranial nerve that exists from the posterior surface of the midbrain. Next nerve is the oculomotor nerve, and as you probably remember, this one is the third cranial nerve. The oculomotor nerve enters the orbit through the superior orbital fissure, where it divides into superior and inferior divisions to innervate the intrinsic ciliary and sphincter papillae muscles and all of the extrinsic muscles except the lateral rectus and the superior oblique. The superior division sends branches to the levator palpebrae superioris and the superior rectus, whereas the inferior division innervates the medial and inferior recti and inferior oblique muscles. This division also supplies parasympathetic motor fibers to the ciliary ganglion. A parasympathetic terminal ganglion located about 1 cm from the apex of the orbit between the optic nerve and the lateral rectus muscle. Preganglionic parasympathetic fibers synapse on postganglionic cell bodies within the ganglion. The axons of these cell bodies reach the eyeball via the short ciliary nerves to be distributed to the ciliary and sphincter pupillae muscles. Now we are moving on to another cranial nerve that you see here in this picture. This is known as the trigeminal nerve. The trigeminal nerve is the fifth cranial nerve. It is the largest of the cranial nerves and it gives off 3 branches: the ophthalmic, the maxillary, and the mandibular. It is a nerve responsible for sensation in the face and certain motor functions such as biting and chewing. For now, we are going to focus on the ophthalmic division of the trigeminal nerve. The ophthalmic nerve enters the orbit through the superior orbital fissure as 3 branches: the lacrimal, frontal, and nasociliary nerves, all serving sensory function only. The smallest branch, the lacrimal nerve, runs laterally superior to the lateral rectus on its way to supply the lacrimal gland and adjacent conjunctiva with sensory innervation. This nerve often communicates with a secretomotor postganglionic parasympathetic fiber for the lacrimal gland from the pterygopalatine ganglion. Preganglionic fibers reach the ganglion from the facial nerve, whereas the postganglionic fibers are distributed to the lacrimal nerve via zygomaticotemporal branches of the maxillary division of the trigeminal nerve. Next nerve that we are going to be seeing here on the lateral view of the orbit is known as the frontal nerve. The frontal nerve is the largest nerve of the ophthalmic division. It courses forward above the levator palpebrae superioris muscle, and midway in the orbit it divides into a medial branch, the supratrochlear nerve, and the lateral oriented supraorbital nerve. The supratrochlear nerve pierces the orbital fascia and supplies the conjunctiva, eyelid, and skin over the medial part of the forehead. The supraorbital nerve exits the orbit through the supraorbital notch or foramen to supply the forehead and scalp. A small twin of this nerve enters the frontal bone to serve the frontal sinus. Next nerve is the nasociliary nerve. It crosses over the optic nerve on an oblique course to the anterior ethmoidal foramen. It communicates with the ciliary ganglion, where sensory fibers may pass through the ganglion without synapting on their way to the eyeball via the short ciliary nerves that carry postganglionic parasympathetic fibers. Other branches, termed line ciliary nerves, are sensory and postganglionic sympathetic, and they pass to the eyeball directly. Branches of the nasociliary nerve also enter the anterior and posterior ethmoidal foramina. Just before entering the anterior ethmoidal foramen, the infratrochlear nerve arises from the nasociliary nerve and passes to the medial angle of the eye, supplying the skin of the eyelids and the side of the nose. The anterior and posterior ethmoidal nerves serves the ethmoidal and frontal sinuses. Internal and external nasal branches derived from the anterior ethmoidal nerve supply the mucous membrane of the anterior septum and the skin over the ala of the nose respectively. The maxillary division of the trigeminal nerve enters the floor of the orbit through the inferior orbital fissure. It is not discussed here because its only contribution of the orbit is a few periostal branches. Last topic that we are going to be talking about is orbital sympathetic nerve pathways. Postganglionic sympathetic fibers whose cell bodies are located in the superior cervical ganglion find their way into the orbit as communications to the several cranial nerves from the carotid plexus. They travel to their destination via these routes or via the sympathetic nerve plexus wrapped around the arteries of the orbit. Nerves destined for the dilatator papillae muscles reach the eyeball either by the long ciliary nerves or by passing with sensory branches from the nasociliary nerve through the ciliary ganglion and onto the dilatator papillae muscles located within the iris via the short ciliary nerves. Now we've reached the end of the lecture. Thanks for watching. Good luck everyone.